Hi, good afternoon, everyone. Can I request our chairman, India, Professor B.B. Thakur, to um, unmute himself, please? Um, well, firstly, thank you so much for coming on at such a short notice. I hope you can hear me well and see me well from my office. Um, I apologize for a minute's delay in joining as I was sorting my technology out. And I welcome you all to this World Diabetes Day 2024, the great cardio diabetes quiz, which is primarily aimed at every single person who's caring for diabetes patients. So very basic, very simple, and hopefully should be interesting to everyone. And somebody and everyone should be able to take something from it, hopefully. And we'll be using some good technology, and we'll practice it like we did last time as much as possible before we get into the nitty gritty of the quiz. Um, I also must thank um, 3 Dot Life Sciences for having provided this technical assistance from so far away, and all of you who are online dot on time, as it's 8:30 p.m. in India. So without any delay, I would like our chairman to say a few words, and then I would be getting into some technology for you all to be comfortable with the quiz side of Element. This quiz is being live streamed on YouTube for anyone to watch, uh, make comments on, etc. So it's one of its kind event. So no matter how many people are here right now, the whole world can perhaps watch us interacting in this wonderful session. Thank you so much. Over to Professor Thakur and Anand. Could you make sure that you pin the speaker, please? Thank you.
Thanks, Dr. Ashish. Good evening, good afternoon, good morning, friends from across the globe. Today being the World Diabetic Day and India being the coming to be the world capital of diabetes, is more so pertinent that we discuss about diabetes, nitty-gritty of diabetes. Our Hridayam Foundation and NBCC, that is North Bihar College of Cardiology, we are engaged in providing the clinical and educational services to the public at large for preventive services and doctors also for the last 2.5 decades. And I must congratulate Dr. Ashish for having chosen this topic for today's deliberations, as it is being the World Diabetes Day. And without wasting any time, I welcome you all, and again, I request Dr. Ashish to start the session.
Thank you, sir. We have about 10 minutes of time, out of which I would like to take 5 minutes. So is there somebody um, who wants to make a comment in the next 5 minutes, taking a minute each? You're more than welcome from the elegant audience who's already joined. I can see people have joined from UK, India, and I can't really make out the rest of the countries. So, Karuna, would you like to make a comment, please?
Yeah, Dr.
Karuna, you need to unmute yourself. Can you?
So sorry. So sorry. Can you hear me?
Yes, we all can hear you.
Okay. Thank you, Dr. Thakur, and thank you, Uncle Thakur, as well, for arranging this. This is one of a kind event. I was very much looking forward to attending this. I've taken half day off to be able to join this because this involves not just India and UK, but the whole world. Diabetes is a hot topic, and I'm sure we will benefit tremendously from it. Thank you.
Well, thank you so much. Anyone else would like to make any comment? We have 3 minutes before I.
Rajendra Sharma, are you there? Dr. Rajendra Sharma.
Smita, are you around to say a few words?
It seems there's some issue with my camera, but yeah, I'm joining from India and looking forward to the quiz.
Great, thank you so much. Anyone else? One of the key things is that unless the person contributing to the quiz join on time, they might lose out on things, and in terms of both participation, their progress, and let's see who is the eventual winner. So we would just wait for a couple of minutes to for more people to get on board. There is, somebody says, iPad, and as a matter of fact, I guess this has been a busy weekend when we have the state level conference of medicine starting tomorrow, but we still thought that we will go ahead with it nonetheless, because this is the only day every year we do things to mark the day, and we had committed to the International Diabetes Federation that we would be doing this as part of our commitment to improving diabetes care. And you would see through the quiz that how interesting it is sometimes to delve into the very basics and benefit from it. And you might see that your practice might change straight away from tomorrow if you reflect on this. So without any further delay, I would ask you to, I would guess that you all have access to Mentimeter. Anand, can you pin the speaker correctly? Thank you. Are you around, Anand? Okay.
Yes, sir.
Yeah, so can you make sure that you pin the speaker correctly? So right now I'm speaking, and soon I'll be sharing my screen. So I have 5 minutes to ensure that everyone is comfortable with the technology side of things, and from your side, feel free to interact as well. We have also notified the local media in Muzaffarpur. We are doing this, and they might wish to take part with an invitation, because some of the quiz is aimed at somebody who might like to just have a flavor of it. Anyway, so have you all got your smartphones with you connected to internet? Can you check, please? And that includes everyone who's here. So please ensure you got your smartphones connected to internet.
I'm joining with my laptop, not
Yeah,
with my
you need to have a separate device with you connected to
Yeah.
internet. That's it.
Okay.
In order to provide responses to the quiz. And can you type in that menti.com? I'm sure you would all have had a proper experience of it, but for today's purposes, if you can just type menti.com, and it will then ask for a code, and I would provide that code very soon. Once I've had an opportunity to share my screen, and then we'll be on our way in the next few minutes. Right, so can you see the screen? I'm sure you all can.
Yes, we can.
So in your screen, on your smartphone, not on your laptop, can you type the code 61087450?
Sorry, can you please repeat it?
It's right on the top.
Okay.
It's right on the top of the screen. So let's spend a few minutes trying to be comfortable with technology, and then we can always crack on with the quiz side of things. I would take from everyone that people are connected to internet on their smartphone. They are connected to menti.com, and they've already typed the code, which is 61087450. Is that correct?
Yeah.
If not, then please you can type in the chat box, and then we can look after it. All right. Okay. Thank you very much. So in about a minute, we'll be getting on with this, but this is all about you being comfortable with your phone and also watching the screen to see the live results. Now and then we'll have a leaderboard where we will see as to who is doing how in terms of how are they trying to get ahead of each other. The longer you take to respond, the less points you get. The quicker you respond, the more points you get, and in the end, we'll have a clear winner. So this is how it's set, and formally, let's start the Great Cardio Diabetes Quiz 2024, hosted by Rhythm and NBCC Foundation on the World Diabetes Day 2024, 14th of November. Thank you very much. So I would ask you to type the city or the town you're joining from. You will see that it'll come up like a little box on your phones. And then submit or press the button. So we have 6 responses you can see on the screen. We have representation from different aspects of Bihar, England, Patna. 7 responses. We might have some more actually. Take your time, there's no rush. Right? Okay, great, good stuff. So this is just to get used to the platform we'll be using and ensure that we are happy with everything. Okay, so it feels nice to connect. I've just been back from India on Sunday, and it also feels so nice to connect with every one of you so soon. Now, this is now we will start the play of the game, and question 1 is just coming. Get ready on your phones. I'm not sure why it's saying 6 players ready. Please ensure that you have typed the code. It's right on the top. It will be on every slide. Menti.com 61087450. So please be ready and please familiarize yourself. There's no rush at all. This is the first question coming through. A simple one. Okay, 30 seconds to answer. On your phones, on your devices. Press the answer before you lose the time. Okay, everyone has voted, and we just have 6 votes. I don't know. I thought there were more people, but for some strange reason, is there a technical issue which you can put in the chat box and Anand can message me? But this is what it's all about. This is how we will be going forwards. And shout out, unmute yourself and say what problem you're facing. It's a small group anyway, so it doesn't really matter. Thank you. Let's proceed further. Right. So let's see. How many times does the human heart beat per day? Some people might know this from last time. Some people might want to take a guess. Those joining late, please, on your smartphone, join menti.com and use the code which is on the top of the slide. Thank you. Okay, so it's an even split. We have about 100,000 beats per minute on an average, and that's the right answer. Thank you. These are just some test questions just to make sure you're comfortable with the platform and the format of the quiz. Excellent. All right. Okay. Which animal does not get diabetes generally? Have you heard of this question before? Oh, some really good responses coming quickly. If we have full responses, we might just close this question sooner. Everyone's voted. Fantastic. Okay, correct. So it's not the rhinoceros, it is the bear. And that's due to the insulin, there's a degree of, due to the weather conditions and few other factors, they are pretty resistant to developing diabetes, especially in the further north side of the Americas and the Canadas and region. So that's an interesting perspective, just to keep in mind. Equally, which animal can turn their diabetes on and off when they want to, which is certainly a hope for human beings. So we have kangaroo, dolphin, polar bear, whale. Do you imagine how much medical students would have benefited by joining this session? And this, I really feel sorry for medical students sometimes who can't get onto these sessions despite our best attempts every single time. So dolphins certainly switch on and switch off as per their metabolic requirements, as per their short cycles and long cycles. They can always turn off and on. I'm sorry, someone is saying something? Okay, so moving on. Seven players ready. Excellent. We have at least got to 7. Let's hope we can get to 10. Remember, I'll answer fast. What is the mean weight of the human heart? Simple question. Take a guess. 1 minute to answer. Two more people to respond, I guess. Okay. Right. So you can see the right answer is an average of 250 to 350 grams, but in certain areas of the world, it can be a bit more. So I would take that for yes as well. It's not something which is too flexible, but that's the acceptable range across the literature review if you had to do it. So 250 to 350, including males and females. Thank you. So how are we doing today so far? I don't think, I don't know who's vote GOAT. They would have an option to put their name or maybe join late. Watson, don't know who that person
Watson is me.
Oh, is that you? Okay, did you not put your name? Somebody remember that for future. Dr. Ojaswini, Professor Thakur, Casper. Who's Casper? Just shout out, please.
Casper is me.
Smita, okay, Deepam, and Aniket. I think, Aniket, are you getting on board with the questions? Are you feeling comfortable so far? Speak out, please. Or are you logged in just?
Dr. Deepam, sir.
Aniket.
I missed the initial few questions. I mean, there were some technical issues.
Understand. But are you comfortable with the platform and everything right now?
Yeah, I'm very new to this platform. I just got to know it today.
Yeah,
So
it's very easy and straightforward. All you need to
if
do is to
yeah,
menti.com at the top. Can you see?
yeah,
And use
the
the
code.
code.
Yeah.
Okay,
Hopefully
you
I'll
will
do
catch
better.
up. You will
Yeah.
catch up soon. I'm pretty
Okay.
sure.
Okay.
Okay,
Okay.
enjoy it and ask your colleagues, WhatsApp your colleagues to join it. But they'll be late, of course, with the rest of the questions. Fantastic. So how many were now we get to the nitty gritty of the quiz. And of course, I'm trying to make it a bit more interesting for you. My camera was giving me trouble, but now it's just come on. So thank you for that. My tech team here in my hospital. So how many people have diabetes as per the latest IDF, International Diabetes Federation data? It's World Diabetes Day today. So roughly take a guess. The trick is to answer on your phone and look at the result on the screen in front of you. Excellent. So we have, has everyone voted? I guess. Okay, the right answer is about 580 million or so, close to 550. That's the right answer. Not 400, not 700. Although it's predicted to go up by 2030 to that figure, or maybe higher, as you would see. So these are very, very basic data for you all to grasp on the World Diabetes Day. We often delve into the fanciful aspects, whereas sometimes we need to take a step back and visit the very basics. Rank these countries in order of prevalence of diabetes. How would you rank them? And you should have the ranking system on your phone, which you could use and then submit. Okay, so we got India, followed by China, followed by America, followed by Pakistan. Any comments? Anyone wants to make a quick comment on that? I'd allow a quick comment. Okay, so the right answer is yes, China, followed by India, followed by Pakistan, and then USA. That is the current prevalence of diabetes ranking in the world in terms of how many people in the country have diabetes. Now, there's a bit of a issue between India and Pakistan currently in terms of the accuracy data, but China has almost twice the number of diabetics than India, which is about 154 million, compared with Indian statistics, which is about 75 million or so. So imagine the burden over there. So China, India, Pakistan, US. That's the right order. Thank you so much. What percentage of diabetics globally you think might be having mental health issues? So this year's theme of diabetes, World Diabetes Day, is barriers, challenges, coping, living with diabetes, so on and so forth. And mental health is now at the top of the agenda. So I'm very keen to explore this in this very small forum. Okay, anybody else? Anyone having technical issues, please speak out. Okay, so none of these responses are correct. The right answer is 85%. So more than 80% of diabetic patients in this world currently have mental health issues. So that is a big take home for you guys. It was for me as well when I was preparing for this. 85% or up to 90% actually, to be very precise. And you can think about it when you take a step back as to what impact diabetes has on people's mental health. Thank you. Atlas of diabetes, how many patients live in low to middle income countries do you think out of 100 diabetic patients, how many would be in low to middle income countries? Because it's typically rich man's disease or something like that, you know? Okay. Please take your time. We have one more response to come through. Okay, the correct answer is about 3/4, which is 3 in 4. So well done for those who opted for 3 in 4 patients of diabetes live in low to middle income countries. That statistics is very much up to date, and you can imagine how much burden of diabetes is there, which is unaddressed compared to some of the developed countries where resources are much more and treatments are pretty different compared to these countries. So there is so much of disparity, actually. Right. How much awareness do you think a person with diabetes might have? So if you have 100 patients with diabetes, how many you think might be aware that they have diabetes or living with the condition? Okay, so the answer actually is about half. Half of the patients with diabetes are not aware that they are living with the condition. And this is as per the latest statistics from IDF and also the World Diabetes Federations, I mean IDF actually, primarily. So, and I was surprised when I saw this because I was not surprised as well as surprised because it varies from continent to continent, and I work across both sides in terms of UK and India, so I can see where the stats have come from and how they reflect the unawareness of diabetes despite having the condition, so on and so forth.
I think it is correct from UK point of view, 60%.
Yeah. Does someone wish to make a quick comment on that?
I said from UK point of view, it is 60%.
Yeah, not far from 50%. So you're correct in a way, if you what is 60%. So in fact, it just shows that, you know, the awareness is pretty low. Any other comments, quick ones?
It should be actually 100%. All patients should know that they have diabetes.
So far India is concerned, it's 25%.
So you mean to say that just 25% of patients are aware that they have diabetes?
Yeah.
Right. Okay, so there is a lot of work to do then, isn't it? There is a lot of work to do. This is a big barrier, and that's what we are trying to explore through this interesting exercise. Thank you so much for your comment. By 2045, what do we think might be the burden of diabetes globally? Okay. Right. Okay. The right answer is 800 million, around 800 million, which not a billion actually. I mean, so far, don't be surprised if it becomes a billion, but we're just going by current statistics. But well done for someone who's voted for 1 billion, because it might be the case actually, the way it's proceeding. So, but for now, it's about 800 million or so, and about 700 to 750 by 2030, 35 or so. Type 2 versus type 1 globally. What do you think is the split? Globally, we're talking global stats. Currently, I'm just talking about diabetes, and I'll be delving into diabetes and cardiovascular very soon. Right. So I think we need to be fair and say that both answers might be right. But if you really had to be critical, then about 10% of patients have type 1 diabetes, 5 to 10%, whereas majority of the others have type 2. So it can't be 20% of type 1 diabetes by any estimate or anything which you might read. So it's 90-10 or 95-5, whatever you might say. Thank you. Right, look at your device. What percentage of world population has diabetes actually? This is now a real question, and you only have 30 seconds to answer. And this covers 20 to 79 years of age. Excuse me. Okay, so about 10.5%, not 15% so far. This is from 2021. Data might be slightly out of date by now, but we just went by the IDF data from 2021, which mentioned that this is what it is currently. Just for your just for our revision purposes. Okay. The most common reversible risk factor for cardiovascular disease in India. 30 seconds. We have to be quick now. Right, let's see. Okay, so the most common factor is hypertension. It is not diabetes, sorry. It is not obesity, sorry. The most common reversible risk factor in India, as per every single study, is hypertension, hypertension, hypertension. So let's focus a little bit more on blood pressure alongside diabetes in our day-to-day practice, because that's something which causes a lot of, it's one of the, in fact, it's the most common cause of cardiovascular disease in India, despite whatever we might consider. We covered this in the World Heart Day quiz, and the answers perhaps more reflected hypertension, and this is a different kind of spread. So thank you for your responses, by the way. Diagnosis of diabetes in non-pregnant people, acceptable criteria. Take a look. The units are both DCCT as well as the IFCC units. Single reading, fasting glucose, HbA1c, postprandial glucose, etc., etc. Okay, great stuff. Yes, so I think every single answer is correct, but for the purposes of the questions, all these criteria, this one is the right answer. You can take a look at the slide. So FPG 26, HbA1c 6.5, 200 pp, single reading 200 or higher in symptoms, so on and so forth. Moving on. Fasting plasma glucose. What is the minimum fasting period required? Those are answers straight away. Go on. This is an interesting question. Generates a lot of interest as to how much do I need to fast before I have my blood sugar tested. We can see it's changing, actually. Right, so the right answer is 8 hours. And 8 hours is the minimum fasting period required, which we say is overnight fasting, full stop. There's no requirement for 12 hours of fasting. So do not fast your patients for 12 hours when you are checking their fasting plasma glucose. The recommendation is 8 hours for overnight fasting if you can time it by 8 hours or so. Thank you. Pre-diabetes WHO criteria 2019. I think there are a few criteria here. HbA1c, fasting plasma glucose, or none of these. See what you think. We are referring to the WHO criteria rather than the ADA criteria. There's a bit of a difference in both. I don't want to drop hints here. Okay, does someone wish to make a comment on this? Smita, do you want to make a comment on this?
I think ADA criteria is 39 to 47, but WHO is still 42 to 47.
Right. Does any of these slides mention any of the criteria which is
No.
non-ADA?
I've gone for none of these.
Okay, the correct answer is none of these correctly. Thank you so much. These are all criteria for different things. This is the pre-diabetes criteria by American Diabetes Association rather than WHO and NICE guidance UK, etc., etc. But this is what we use internationally, but it's not the WHO criteria of 2011 and 2019 respectively. So just to keep in mind, this was a slide to confuse you all a little bit. Thank you very much. Prediabetes and cardiovascular risk or cardiovascular disease. Now we are getting a bit more serious about the heart, which is correct. This is from a large meta-analysis, or the largest one actually. Which one is incorrect, or whatever you feel. It sends a very strong message actually to somebody who you're seeing and telling them that you haven't got diabetes, but you got pre-diabetes. They get confused as to what's pre-diabetes, and but you need to explain to them so on and so forth. But the meta-analysis results are very clear that there's across the board the risks pretty much literally the same, if not higher. Thank you. Ranolazine, we use this almost in every patient in India with angina. What is the mechanism of action? Almost every patient is on ranolazine 375, 500, 750 BD or 1 gram. How does it work actually? Okay, so ranolazine basically is a fat metabolism inhibitor, and is a metabolic modulator. So this is just a take-home message. It doesn't do anything to the glucose metabolism. It doesn't increase fat metabolism, and it inhibits fat metabolism, in fact, and tries to shift the metabolic pathways within the myocardial cells, which in fact result in reduction of symptoms, and many a time placebo effect. But this is now a standard therapy. I wouldn't say first line. No way. I think we tend to use it first line in many patients in India. But we shouldn't be using it as first line treatment unless there are no options. So this is what the right answer is: inhibition of fat metabolism. Thank you. Okay, so get ready and answer fast. Angina and diabetes, every single medication is a metabolic modulator except. You have 30 seconds to answer. Right, so ranolazine is a metabolic modulator. Trimetazidine is a metabolic modulator. Perhexylene is a metabolic modulator. But cetirizine, of course, is not. It's an anti-allergic medication. Thank you. Simple question. Electrocardiogram. 70-year-old diabetic with stable angina. Beta blocker, ARB, antiplatelet, statin, and nitrate, basically as a SOS, is getting dizzy spells. Take a good look at the ECG before we move on to the next question. I hope it is visible on your screens. He could be coming to your clinic. He could be coming to a GP surgery. He's on polytherapy, but he started to have dizzy spells. And having looked at the ECG, what do you think is the ECG diagnosis? Look at your device. Okay, so the right answer is fine atrial fibrillation rather than any of the other ones. Let's go back. So take a good look. The rhythm is irregular, firstly. There are established fine fibrillatory waves, which you can see in the right precordial lead, V1, V2, V3. Where you would normally see the atrial activity best, apart from the some of the limb leads where it's not exactly visible. But this patient has traditionally what we call is slow atrial fibrillation, and the question next would be that what would you do as the next line of action? It can confuse these kind of ECGs in terms of sinus node disease versus other forms of, it wouldn't confuse you with heart block, but basically you would worry about sinus arrest and all those things, sinoatrial disease. Okay, so somebody thinks pacemaker, somebody thinks beta blocker to be stopped. Someone says increase beta blocker, well, that's going to kill him perhaps. Reassure, well, he's dizzy, he won't be reassured. Pacemaker, perhaps we would wait. So the right answer is stopping the beta blocker and reviewing, and then trying to see how they do with a repeat ECG. And if they're still symptomatic, then perhaps proceed with a permanent pacemaker off rate limiting medications. Is that reasonable? Thank you. Right. Mute, thank you. Anand, can you put them on mute? Thank you. This is a very interesting question. Lipid profile assessment and accuracy of fasting. Again, fasting glucose, fasting lipids. Does it really matter? Yes, no. Maybe some quick comments might help, but okay, right. So I think in the current time, we don't need fasting lipids. We just need a random sample, unless you are specifically testing for triglycerides. and that too in a specific manner in someone who is hypertriglyceridemia. So otherwise, you would just go for a random sample. The criteria went away a few years ago. It's not new. So don't fast your patients for 14 hours, 12 hours, so on and so forth. The right answer is no fasting. Thank you. Great. I think we're doing quite good. The LDL target for highest risk patients with diabetes and cardiovascular disease. How low would you go? We know the lower the better, but then how low would you go? What would you aim for? Okay. Right. So most of you have voted 70, but the correct cutoff is 55. Remember, it's very clear as per the ESC guidance, as well as is 55, less than 55 for the highest risk patients with diabetes and cardiovascular disease. We will come shortly to the highest risk, that what defines highest risk perhaps soon, because we need to move on a bit more quickly. As to the next question, recommended initial dose for atorvastatin. That's an easy one. I'm sure you'll handle it, and we should have 100% correct response on this. Interesting. Okay, so 10-20, no, big no. 20-40, big no. 20-80, big yes. 10-40, big no. So 10 is nowhere unless someone's intolerant. 20-80 are the standard doses unless you have a reason, unless there's a mitigation, unless there is a particular reason not to give that dose. These are the standard doses for primary and secondary prevention of cardiovascular disease in diabetics.
Sorry, I voted, but it didn't go through.
Sorry?
I voted, but for some reason it didn't go through. My answer was correct.
Your timing might have timed out.
I thought I did, but perhaps I didn't.
Yeah.
Okay.
Anyway, I mean,
It's all right.
that's the right answer. Anyway. Moving on. What is the recommended planned physical activity? What would you tell your patient? वो कहता है मुझे कितना एक्सरसाइज कितना क्या करना चाहिए? What would you say? This is taking away their routine day-to-day activities, work, job, etc. Okay. Fantastic. So this is, perhaps I'll take a screenshot of this as a slide which has 100% response of everyone's voted pretty correctly, and thank you for that. So it's 150, which is 30 minutes, 5 days, and need not be any more. Actually, in fact, the evidence is coming about 120 and all that stuff, but currently still 150 minutes advised prescribed exercise in different forms suitable to the patient, bespoke to their physical abilities, so on and so forth. Right, leaderboard now. Let's see. Vote GOAT. Who was vote GOAT? Remind me, please. Shout out, please. Who's
Hello.
vote?
This is me.
I don't know your name, sir. Please spell.
My name
I
is
can't
Dr.
see.
Shubham.
Fantastic. Well done, sir. Professor
Dr.
Thakur's leading second, Karuna third, Casper, Deepam, Aniket catching up. Thank you. I hope you're enjoying. So this is where we just review now and then as to who's doing how. Thank you. Let's see. Move on. SGL2 inhibition. Who would you prescribe for except in diabetes and heart failure? Everyone's voted. Time is key. So EGFR less than 15, correct? Less than 30, well, no, not sure, not too sure, not too correct, perhaps. So the criteria for SGL2 inhibition is that EGFR should be less than 15, but you shouldn't be giving it. This is a relative, not an absolute contraindication. Thank you so much. Unless there are other factors prevailing. This is like a binary question. So, okay. So, most common cause of angina in diabetics, especially females. 30 seconds. Obstructive disease, spasm, resistance, or dissection. Okay. Everyone's voted. Right. So it's not spasm, maybe spasm. It's not obstructive CAD as the most common cause. Most common cause is high microvascular resistance, or what we call as a microvascular angina, which is the most common cause of angina in females. Coronary spasm generally manifests differently, both clinically, electrocardiographically, whereas microvascular resistance manifests differently and is the most common cause worldwide of angina in diabetic females and females in general, actually. So that is something which please type the average number of diabetes and cardiovascular disease patients you see per week. Now that's on your phones. Okay. Okay, great. 40 patients. It's a high number. 100. Century. 7 responses. What? Wow. So that's a really wide range, and thank you for submitting your answers and sharing your caseload, which shows that everyone's engaging with diabetes and CVD. Thank you. Do you think in developed or developing countries or nations, diabetes and cardiovascular disease are well managed? Look at your devices for your response. Okay. So we're leaning towards well managed. Okay. Unable to comment. Fair comment. Unable to comment. Pretty fair. Poorly managed. So we are leaning more towards poorly managed now. Right. Yeah, it's correct. And in general, it's poorly managed, and we don't want to discuss the specifics of it, but you can think of 100 reasons why it's poorly managed and how we can make it better. but the right answer is poorly managed rather than excellent or well managed, so on and so forth. Now, high risk or very high risk cardiovascular categories in diabetes. We referred to the LDL criteria of less than 55. But who would you say is very high risk? Now, this is except, mind you, okay? Which means 3 of the 4 are very high risk and 1 is not. And that's what you need to pick up. All right, so we say, not we, but the international bodies and the European Society of Cardiology, as per its latest guidance, extensive guidance on diabetes and cardiovascular disease, came out with this fantastic and extensive document, risk stratifying diabetes and cardiovascular disease. Very high risk is where you have this, and this. More than 15%, of course, doesn't really come in. So well done for those who opted for this. All of this is very high risk. So sorry for you guys, but this is all very high risk. This is moderate risk, between 10 and 20% or so. Thank you. How much weight loss as a minimum improves cardiovascular risk in obese diabetes patients? As a minimum, how much weight they need to lose in terms of percentage? There is a cutoff figure, mind you, and that's trial and evidence based. I wouldn't put this question otherwise. Thank you. We have a pretty even split here, 10%, 8%, 6%. And in the interest of time, I think we need to move on. So the right answer is more than 5%. So this is the right answer, which is 6%. Although I would say 8% is right, 10% is right as well. So they're all correct. But yeah, 3% is not, less than 5%, no. So they all lead to the major reductions in all the 3 key parameters, which we look for in terms of reduction in cardiovascular risk. So just a general perspective. Glycemic targets in diabetes and cardiovascular disease for people with long life expectancy or young patients. Now the units are in both DCCT and international okay. Anyone wants to make a comment on that from India or UK or?
In younger people, it should be less than 6.4. However, in the aged ones, it could be less than 7.5.
Yeah, what is the international agreement and what's the evidence behind it, sir? There are established guidelines around this, which tell us, we're not getting into this because of the time lag, but thank you for your comment. That for people who are young and people who with long life expectancy, target should be stricter, but with a caveat that we must ensure that hypoglycemia should be avoided or steps to be taken to avoid hypoglycemic episodes. Now, does metformin really have a cardioprotective effect in diabetes? Wow. So in the small group, 2 people are not sure, 4 say yes, and 1 says no. Who says no? Can I have them to say, to spell their name? Who says no?
Good evening, sir. Dr. Ojeshwani here.
Dr. Ojaswini, you are absolutely correct. There is no evidence based on extensive meta-analysis that there's no benefit whatsoever in terms of any reduction in cardiovascular outcomes with metformin. Studies have been done, but there's been no randomized study of reasonable size, power, or anything with metformin. The largest study was the clustered part of the randomized study of UK-PDS where metformin was studied, but again, there was no statistical difference found at all. So yes, metformin, as it's widely thought, has no cardioprotective effect, so do not prescribe metformin thinking that it's going to be of benefit to the heart. In fact, if you have to, then give your patient an SGLT2 inhibitor, which will give the right prognostic as well as cardioprotective benefit instead. Thank you very much. 13 RCTs, including UDPDS. This is what I was saying. Which parameter was significant? Now, you might take this question, but I've already answered it. So the 3 parameters tested were MI and cardiovascular death, all-cause mortality, peripheral arterial disease, but none of them are found to be statistically significant. So it has its own role, but not in terms of cardioprotection. Glycemic targets in older patients with less life expectancy. Okay, 53.7. 69.8.5. None of these. Right. The correct answer is 69.8.5 for all the patients with less life expectancy. Don't be surprised because that's a decent target. And that's what's agreed internationally. When we push to this range, we are putting them at risk of hypoglycemia and also other effects, which could include the musculoskeletal system, weakness, tiredness, lethargy, hunger, all sorts of things in old age, so on and so forth. So that's the right target, which has been agreed with diabetes and cardiovascular disease for older patients, so on and so forth. We have 15 minutes. We had thought we will close at this point in terms of comments and all, but are you happy to proceed with a few more questions and then we can close at 10 p.m. India time sharp?
Yes, please.
Say yes or no.
Yes, please.
Can we have some more people saying yes?
I will have to leave.
Okay. I mean, now or?
Now.
Yes, please.
Okay, thank you. I will carry on, and people who have bothered to join, I must thank everyone. Thanks, Smita, for your contribution, and we will move on in interest of time. CAD and diabetes, pick the ones as first-line therapy to reduce the cardiovascular risk in your practice, in your clinic today, independent of glycemic control. Right? Okay, so metformin's a no. We have only two options here, which is GLP-1RA if it's available, or SGLT2 inhibitor. Metformin doesn't really affect the cardiovascular risk, as we've just discussed and shown. And again, here we are talking about independent of glycemic control. So both of these medications, they act through different mechanisms, and they provide the right responses. So remember, if you really have to, then start them on this as your first-line therapy than anything else. And then add metformin if needed. Thank you. Diabetes, low bleeding risk, no cardiovascular symptoms or cardiovascular disease. What is the consensus on aspirin? It's widely used around the world, around India, wherever. 1A, give to all. 1B, consider for all. 2A, may give to all. 2B, may give to all. Where do we stand with aspirin today? Would you take the call on aspirin and give it to your patient? This is an important take-home question for you guys. We'll promptly finish in 10 minutes time, 10, 11 minutes. Okay, so the right answer is class 2B. That was agreed as per ESC guidance on diabetes after extensive review of literature, etc. That if you have a patient with diabetes with low bleeding risk, mind you, youngish patient, no symptoms, no established cardiovascular disease, you may consider aspirin for first serious cardiovascular event, full stop. And then agree with the patient that they're happy to take aspirin or they want to take aspirin, full stop. There's no class 1 indication that you have to give it to everyone. So that is a no. This is maybe, again, class 2, B indication rather than class 1. So just a take-home message. Have a chat with the patient, see what they feel, see what their cardiovascular risk stratification is, and then discuss with them. Thank you. Will you give dual antiplatelet therapy to stable diabetics with or without cardiovascular disease? In India, we have combined formulations available where they have not had revascularization like stenting or CABG within 12 months, so on and so forth. I mean, they're available as standard therapies, aspirin and clopidogrel. So the answer is no. Yes, there's no need to. You shouldn't. It's dangerous, and it can cause litigation if somebody dies of a GI bleed. So it's a big no for stable patients with no revasc, etc. Patterns of CVD in terms of acute coronary syndrome across the globe. I just wanted to highlight this because we've seen a lot over years. So see what you think. There are not too many questions to go through, so right. Well, thank you for that. So I think every option is correct here. I wanted to highlight that they could be having typical chest pain. They could be having just breathlessness or an equivalent of angina or ACS. Abdominal symptoms are very common. We just had one last week when I was in India. and all of these, of course. And there could be more. You'd be having all sorts of experiences of ACS. And again, silent myocardial infarction is so common because of autonomic neuropathy in diabetics, where they come to you with an evolved infarct on Q waves on ECG and echo showing LV dysfunction, and there you go. I mean, you just have to medicate them and then discuss with them what exactly they need going forwards. Diabetes, acute MI, and current generation of stents, which is pretty up to date, the best metal around, minimum dual therapy. Normally you would give them for 12 months conventionally. But if they have high bleeding risk or they have AF, atrial fibrillation needing anticoagulation, where do we stand in terms of consensus, agreement, guidance, this and that we can stop the second one at this point and start them on apixaban, dabigatran, rivaroxaban, etc., as single antiplatelet and anticoagulation. Thank you for that. So the right answer is 1 to 3 months, and there is a sliding scale you can use depending on the ischemic risk versus bleeding risk, but the minimum is 1 month to be precise with the current generation of stents that you can stop at 1 month and proceed with the rest of the stuff. So I just wanted to highlight that for the benefit of the group. Diabetes and heart failure phenotypes seen in practice. And I just wanted, again, it's more of a comprehensive slide, that do we just see one kind of heart failure with mild ejection fraction, or do we see reduced or preserved? Yeah, so I think we're leaning more towards mild ejection fraction, but to be honest, don't be surprised if you come across majority of your diabetic patients in this category of normal or mild, normal or borderline ejection fraction. So all of these are correct responses. And this is a HFpEF where they're just breathless. You give diuretics and they feel better. So, and that's proper heart failure, systolic heart failure. And that is just something which is in between. You give SGLT2 inhibitor, some diuretics, and hope for improvement in LV function and rule out coronary disease, so on and so forth. Reduced ejection fraction, prognostic medications, which is not the prognostic medication out of these. Okay, so in all honesty, it's just the loop diuretics which are not prognostic. They are just symptomatic for congestive symptoms, whereas beta blockers, SGLT2 inhibitors, and mineralocorticoid receptor antagonists, spironolactone, eplerenone, whichever you use, they're all prognostic. They all add to the years of life. So bear in mind, this is only for symptoms when someone is overtly congested or decompensated. These are all prognostic. So if you're not using them, then you might want to change your strategy of managing a heart failure patient. Thank you. So let's see where we are now. Right, so at the end of the quiz, vote GOAT. Who's vote GOAT?
Hello, this is Shubham, Dr. Shubham from
Dr.
Bhagalpur.
I think you won the quiz.
Oh, thanks a lot, sir. Thanks a lot.
with 9,938 points. Shortly followed by Professor B.B. Thakur with 8,338 points. And then followed by Karuna Sharma from UK at 6,590 points. Congratulations. And that brings us to the end of the quiz segment. Let me make sure that I stop sharing, and we'll come back to this before we close in 3 minutes time. Any comments somebody wants to make about anything in particular? So Dr. Shubham,
Doctor,
can you in the chat box write your full postal address, and I'm going to post you as a prize to every number 1, number 2, and number 3.
okay,
Heritage
okay.
Foundation water bottle. As you can see here, it's pretty nice as a keepsake, but I will aim to give it to everyone who's participated today as a token of respect and gesture on having come late as per India time. So we will have this attendance sheet, and we'll contact you by email to give your addresses so that we can get them out to you as soon as possible in the next few weeks' time. So thank you very much. So winners, Dr. Shubham, Professor Thakur, Karuna, congratulations. Anyone wants to make any quick comment before we close?
I would say I thoroughly enjoyed it, learned a lot from practical aspects as well. It's nice to compare the statistics and data and problems with the patients between UK and India. That gives us a lot of insight in diabetes management. Thank you very much.
You're welcome. I think I didn't want to make it too cardiology heavy, otherwise it becomes difficult. On World Diabetes Day, where diabetes is the theme. And anyone else wants to make a quick comment? Do we have our chairman? I think they might have left by now. So anyone wants to make any comments, sir? I can see some names here. Dr. Jaswal, Dr. Deepam. There's a name called Neha's iPad.
Actually, I am Dr. Ewan Thakur. I am using my daughter's iPad. I am in Abu Dhabi.
Oh, so, wow, sir. So you should have said that before that.
I joined late. I joined late, so I could not vote even.
I'm sorry about that. I'm sure we will have it. We have it every month almost, something like this. And I'm sure if you can just write your email address in the chat box, I'll make sure that I'll send you the invitation soon.
Okay.
Unless you're part of some form of API or
I'm already involved with this API and Epicon. Actually, I will be leaving for India and a couple of days back. After, I had a regular talk with Professor B.B. Thakur on phone and on the mail also.
Thank you for coming on board from the Middle East. It must be, it shouldn't be too late over there, I guess. I guess it might be about 3 hours, 3.5 hours. I'm confused, so I might be wrong. Dr. Deepam, any quick comments?
Yes, sir. Good evening, sir. Myself, Dr. Deepam sir, I am a final year PG resident medicine in Army Hospital R&R, Delhi.
Wow.
So I am enthralled, sir. This is a very good platform for me, and I got to know
Yes,
a lot.
and I'm sure you'll be asking your colleagues to join and enjoy.
Yeah, definitely. But
have fun.
on a short notice, I could not invite much of them, but I
No,
invited.
it's all right. If you just, I mean, I literally came back from India on. It was a busy festive period, and I
Yes,
had
sir.
committed to IDF that
Right,
we would do this today, and I was up since 2 o'clock. Nicely, I was jet lagged, so it was easy for me. So,
Yeah, right, sir.
so if you just type your email address in the chat box, I'll make sure that
Definitely,
everything
sir.
goes back to you for the next event. We have our big event called Sudden Cardiac Death. Session 2 coming up on the 15th of December. I will request
Right, sir.
everyone to make a note. It's a Sunday, mind you, so it shouldn't be too much of a hassle unless your calendar is full.
Sir,
it's
I would
focused-
like to request you, sir, on one thing, sir. I'm really interested in lots of quizzes, sir. So whenever you are conducting any quiz, so kindly let me know so that I can attend.
Yes,
and
indeed.
a bit more on therapeutics and all recent therapeutics. We can have a
Yeah, and I think today the focus was more on awareness and
right, sir.
even I learned lots of things along
sir.
with you guys. So it's just a way of keeping engaged. And from tomorrow we have a Bihar state level conference, and I've been entrusted with a very difficult topic called why do we struggle to manage cardiac patients in Bihar? So that's my topic for Saturday. And then we are having this big meeting, which you're more than welcome to join on 15th of December, Sunday. The details are going to be worked out and sent to everyone soon. It's focused on sudden cardiac death. We have already done one session this year. This is the second one of the series as to how we can improve cardiac arrest care in Bihar. So it's all focused on Bihar, India widely, so on and so forth.
Right, sir. Thank you.
So with that, I guess we've come to close. Thank you, Karuna. Thank you.
Thank you, Dr. Thakur.
Thank you, Anand.
Thank you very much.
And please have a good, nice, and relaxing evening. And enjoy the Capricorn if you're attending it from tomorrow.
Okay.
Good
night.
Good night.
Thank you and good night. Thanks. Anand, are you around? Anand, आप हैं?
Yes, sir.
आप 2 मिनट वेट करें, बस 2 मिनट बात करनी है आपसे बस.
You should wish luck to Mama, na? Good luck, Ma. Mama, I hate you. If Mama says this to you, you will cry so much.
आनंद आप वो YouTube का लिंक भेज देंगे.
ओके सर.
और रिकॉर्ड आप कर रहे थे इस सेशन को?
यस सर, ये रिकॉर्ड वही सर YouTube का लिंक पे ही रिकॉर्ड हो गया पूरा.
तो वो तो उसमें रहेगा ही ना?
जी.
ठीक है, थैंक यू सो मच. हैव अ गुड नाइट एंड फिर बात होगी हमारी.
गुड नाइट सर.
गुड नाइट. टेक केयर.